Hi, my name is Richard Rosenfeld, and I'm speaking to you today in my role as chair of the Performance Measures Task Force for the American Academy of Otolaryngology Head and Neck Surgery to share some very exciting news and update you on the Regent, specifically how our performance measures are going to help you in your practice, meet quality reporting standards, and provide better care of your patients. Most of you have heard of the Centers for Medicare and Medicaid Services, that they have quality reporting standards, and our Academy has been very proactive in helping you comply with those through various programs. The problem is that Medicare has changed. The sustainable growth rate formula was repealed by Congress this past year, and in its place we have MACRA, the Medicare Access and CHIP Reauthorization Act, which was signed into law in April of 2015 and repeals the sustainable growth rate, which raises the immediate question of what's coming in its place. Just when you were used to seeing these wonderful graphics from our Academy available on the website about the PQRS system, Physician Quality and Reporting System, or perhaps the value-based modifiers and how to comply with those, or even the electronic health records incentive program, the rules are changing. So, in the context of a Jeopardy question, let me ask you, these are the building blocks of all the quality reporting systems, whether it's PQRS, the value-based modifiers, EHR incentive, or even the new MACRA project, and they are performance measures. So if we really want to understand quality reporting, whether it's the registry, whether it's MACRA, or even our existing systems, we need to focus on performance measures, and that's the purpose of this presentation, to help you understand what they are and how they're going to help you provide better care of your patients, and importantly, document that care so others know of the quality care you're providing. So let me begin by showing a sample performance measure, one of the measures we developed for acute bacterial sinusitis. And a measure consists of a numerator, as shown here. In this case, the patients who were prescribed amoxicillin, with or without clavulanate, as the first-line therapy for their bacterial sinusitis at the time of diagnosis. And we specify that in some detail, as you can see, including appropriate G-codes. We then follow that with a definition of the denominator. In this case, all the patients, adult patients with a diagnosis of acute bacterial sinusitis who were prescribed an antibiotic. By then dividing the numerator and denominator, it shows the proportion of patients who met compliance with the recommendation. The rationale is always shown on a performance measure, and it's specified here as the role of antibiotics and why the selection is recommended of amoxicillin with or without clavulanate. This rationale generally comes from clinical practice guidelines that correspond to the measures and are used to generate the measures as a secondary product. So let's get back to CMS and the Center for Medicare Services. What have they done? What do we need to speak about? Well, first, MACRA. MACRA is the big project that's replacing and ending the sustainable growth rate. And within MACRA are two affectionate items called MIPS and APMs. So MIPS stand for Merit Incentive Payment System, Merit-Based Incentive Payment System, which basically combines all the old systems into one grouping. So PQRS, the value-based modifiers, the EHR incentives, these all now come into this MIPS concept, which is going to rely heavily on electronic health record technology. In addition to that are the alternative payment models, which offer a new way to care for Medicare beneficiaries. The main importance here is that people who find themselves in an APM through their hospital-based program or others, that can take the place generally of the merit-based incentive payment system. So if you're in an APM, you probably don't need to listen to the rest of this presentation, but it may be relevant. What has your Academy been doing? Well, the Academy has been very proactive in addressing the need for measures, specifically to enable the registry to exist and measure the right data. So we've been advocating extensively. We've been working with the National Quality Forum to endorse existing measures on acute otitis externa and otitis media with effusion, which has been successfully done. We've refined the list of pilot measures for the Regent registry, including 6 new outcome measures that I'll show in a bit, as well as a new process measure. We're working closely with our vendor for the registry, FigMD, which has extensive experience in helping specialty societies do this efficiently and, more importantly, effectively, to create a data dictionary. And we've developed even a draft protocol for creating performance measures that will comply with the evolving Center for Medicare and Medicaid Services rules, which are still not finalized at the time of this presentation. The ENT registry, or Reg-ent, is going to offer a lot of advantages for public quality reporting, demonstrating alternative payment models. Once it's established, it will allow a very cost-effective way to develop what are called e-measures, measures directly from the registry that save a lot of time and expense, as opposed to deriving them from guidelines or Denovo and then first having to test them and go through beta phases. So the registry is very important. In healthcare, when we talk about quality, we begin with our guidelines. Our guideline program has been active since 2005. We've developed a core of multidisciplinary guidelines throughout the specialty, and these help define quality. Without guidelines, it's hard to say, what are we aiming for? What are the quality actions that clinicians can take to improve care? The registry helps us track this, but the measures are really what assess quality. They allow us to measure in a very pragmatic way, hopefully using EHR data entirely, seamless to the clinician, what we're trying to track in the guidelines. The measures, or performance measures, come in different types. For example, measures of outcome and process would be the most common ones. Our guidelines have typically provided measures of process. Did you prescribe an antibiotic? Did you arrange a follow-up visit? Did you measure your hemorrhage rate after tonsillectomy? These are all process measures that can be tracked fairly readily in a cross-sectional way. They often relate to testing, to imaging, getting or not getting a recommended study or intervention, and they can be used in clusters of groups managing a disease. So for example, in sudden sensorineural hearing loss, related to imaging or testing and audiometry, etc. The outcomes measures are a bit more complex in that they often require multiple time points to really get an answer to what happened to the patient. They may be as simple as mortality, readmission, a revision surgery or complications, or a little more complicated using validated health-related disease-specific quality of life measures that allow us to track within an individual how they're doing at multiple time points. Importantly, these often need risk adjustment for the severity of disease and issues related to the patient as well. These are preferred by CMS, the Centers for Medicare and Medicaid Services, and others, and will need to be an integral part of our registry going forward. Just 2 examples of some outcomes-based process measures. The affectionately labeled SNOT-22, or Sinonasal Outcome Test, which tracks quality of life for patients with chronic rhinosinusitis. So a patient would complete this at various time points. It would generate a score. You could look at the differences in the score over time to track how the quality of life of the patient is doing. The same thing applies to the OM6. Not quite as sexy with a name, but a very well-accepted survey on otitis media for children, for chronic or recurrent otitis media, allows very rapidly to assess the quality of life in the child over time. Both of these, as well as other measures, can be effectively incorporated into EHRs to allow us to seamlessly, at the point of care, collect this information and then use it to generate our registry-based measures in the future. The benefits of these outcome measures in a qualified clinical data registry are multiple. We really are going to be on the cutting edge of quality reporting that meets the standards. It allows us to do very interesting things, track natural history of diseases. There's really a paucity of this in the literature, and we can get excellent information over time if these outcome measures are routinely used, as well as, of course, the impact of what we do. It sets the stage for really relating all our process measures to outcomes, to bridging the gap, because the process measures are often in the EHR already. And ideally, working with our vendor, FigMD, this becomes a seamless process. The information in the EHR automatically maps into the registry. We, of course, have to identify the right outcome measures, and our Regent structure, governance structure, will be doing that to be sure we get the right outcome measures for the various disease processes and problems we're interested in tracking. This is going to help tie satisfaction to outcomes, deal with maintenance of certification efforts, and even reporting and licensing requirements, because increasingly these bodies want to not just know if you're doing what you're doing, but if your patients are satisfied and having the outcomes that we wish. We're going to be able to generate data that could be of use to hospitals, insurers, healthcare systems, the Food and Drug Administration, which other subspecialty societies have resulted in a nice profit being able to make these data available to interested individuals to recoup the cost of maintaining the registry. So let's get down to the more practical aspect of how do we actually develop measures. And I say this with the caveat that it is a work in progress and still has to evolve based on what CMS decides they want to see in the registries. Clearly the low-hanging fruit are the PQRS, the Physician Quality and Reporting measures that we already have in place. All we need to do with these is develop some measure specifications, support for the EHR, and boom, they're in the registry, and this is what has been done to prime the registry for its launch. Above and beyond that, we can rely on our clinical practice guidelines, which, as I mentioned before, define quality. We take these guidelines and, using our new measures development groups, which I'll speak more about in a few moments, the measures groups can take the key elements of the guidelines and draft valid, relevant, evidence-based measures that build upon the guideline to define the actions, processes, outcomes that we want to see happen that are sought in the guideline itself. An alternate way is what's called the Denovo pathway. If there are important disease entities, conditions, procedures that are very relevant to our membership, and it may be even something as simple as coming up with measures for office-based nasopharyngoscopy, office-based laryngoscopy, which are two procedures heavily scrutinized by CMS. Or perhaps it's a subspecialty interest that's not covered in a guideline. Well, we can start from scratch, identify the outcome measures, the best practices, the QI opportunities, and then feed these into our measures development group and again draft measures. So 3 ways to do it: from scratch de novo, building off a guideline, or from the existing PQRS measures. Playing into both of these are the guideline development groups that work hard to develop the guidelines, and the Regent executive and advisory committees, the governance structures of regents that help prioritize these de novo methods and come up with suggestions for what they should and shouldn't be. So let's speak a little bit about the PQRS measures, what I just referred to as the low-hanging fruit. So these measures are based directly off measures that we already have approved and are active in PQRS. Some of them are measures that we have developed specifically for otolaryngology, others are related. And they're shown here by the national quality safety priorities of patient safety, person and caregiver-centered experience and outcomes, communication, effective clinical care, community and population health, and efficiency and cost reduction. You could look at these and say some of these are not relevant to me, and that's understandable because they're not otolaryngology specific measures, but we've attempted to include as many as possible to allow people to get on board and transition their PQRS efforts into the registry. So beyond the PQRS Regent measures, we've also included some guideline-based measures. So these are measures not in the PQRS program yet, but we've developed them especially for the registry to make the registry as useful as possible from the launch. They're shown here. They emphasize patient safety. So for example, measures focusing on tonsillectomy hemorrhage in children and adults. Person-centered care, looking at resolution of otitis media with effusion in children and adults, and effective clinical care, things that were again drawn from the otitis media with effusion clinical practice guideline that was updated and published in 2016 about hearing testing, assessing the eardrum, and prescribing, or in this case not prescribing, medications. The Denovo process, which has not been discussed so far, is where we don't use the PQRS system, we don't use the guidelines, but we instead attack a specific need identified by the Regent Governance as being important to measure. The Denovo measures can be potentially based on a guideline or even our consensus statements. More often they're probably going to stem from specialty or subspecialty interest or high utilization CMS procedures or diagnostic codes. And they're going to lead to a need for articulating a measure, which then goes to the measure development group to be drafted, validated, and specified, eventually put in the registry for testing. Here's the Regent Governance, which is important to understand. So the Regent structure, the registry structure, does have a governance associated. At the top is the Board of Directors and Executive Committee, and then importantly, there are 7 specialty-specific areas: facial plastics, general otolaryngology and sleep, head and neck surgery, hearing and balance, pediatrics, sinus and allergy, voice and swallowing. These advisory committees are the ones that decide priorities, that help with measure development, that define outcomes, help with risk adjustment. They will propose and prioritize the measures, and a lot of the people who are on the measure development groups will be populated from these advisory committees. They're also going to have a role in helping the measure groups identify the current best evidence to really support developing the measures. I'm showing here a comparison between the measure development group and the Regent Clinical Advisory Committee because this is an important distinction. So the groups will focus on methodology and they only exist for the duration of the measure. In contrast, the advisory committees, they're strategy driven. They have multi-year terms. The roles of the measure group is to really develop the measure, whereas the Clinical Advisory Committee is proposing the measure and prioritizing the measure. The oversight for measures development comes from the Performance Measures Task Force. In contrast, for the Regent Clinical Advisory Committees, the Executive Committee of Regent is overseeing that. The composition of a measure development group is measure specific. We're looking for the specific individuals that we need to get the relevant content experts to really effectively derive the measure. Whereas the advisory committee groups are not necessarily content experts on everything related to the measure. They're driven by the specialty. So the laryngology advisory group has laryngologists who may or may not be experts on everything related to a given measure. Similarly, a measure group may draw upon multiple specialty groups to derive its members, which don't necessarily come from a single Regent Clinical Advisory Committee. The members of the Clinical Advisory Committees are all content experts for that area. Now, consumers may be involved in this. We will likely strive to have some generic consumer involved in the measure development process, since this apparently will be a CMS standard. As far as the consumer role in the Regent and Clinical Advisory Committees, that's to be determined in the future. There are some reporting standards for how to develop measures. For guidelines, we have tons of reporting standards coming from the Institute of Medicine and the Guideline International Network, as well as others. But for measures, it's a bit of the wild, wild west right now. There's very few publications, so the methodology is evolving. The concepts that seem inherent to all of them are a guideline selection process, a way to state the grade and evidence strength behind any measures, to have an explicit way of creating the measures from the guideline recommendations, specifying core measure attributes such as the relevance, scientific soundness, and the feasibility of actually doing the measure, specifying the numerator and denominator clearly, the intended use. Some of these are specifically for quality monitoring purposes, some are for reporting and credentialing. The process that was involved in crafting the measure and testing and piloting it needs to be determined, as well as the composition of panel and criteria for changing or discontinuing. So these standards will all evolve, and these listed on this slide only apply to guideline-based performance measures, although there will be some commonality with the de novo measures as well. It was Galileo who said we have to measure what is measurable and make measurable what is not so. So performance measures simply are attempting to make measurable all the great advice in guidelines and the advice provided by the specialist and the Regent advisory committees. And I think it's important to stress that by doing this together, we'll do it best. So what do I mean by doing it together? Well, what I don't mean is what's shown on the slide now, which is having lots of clinicians doing their thing, having the academy doing something else off in the distance, and then every specialty and subspecialty society doing their own thing to try and address the quality conundrum. We need to talk to each other, and we need to communicate, particularly between the academy as well as the subspecialty societies and groups. And venues for this include the Subspecialty Advisory Committee, the Guideline Task Force, the Performance Measures Task Force, the Regent Governance structure, especially the Clinical Advisory Committees, the Board of Governors, the Core Grants Program. There are other ways, but we need to communicate and build on strength. The strength that we need is a way to effectively influence and build our credibility outside the House of Otolaryngology with CMS, with the Institute of Medicine, with other groups, the AMA, for example, Guideline Network, Cochrane. These are the groups that we want to work with and garner respect. We're most likely to do that not through the specialty groups, but through the academy. It's really the specialty unity that's going to allow us to work together and have a disproportionate influence in the greater House of Medicine beyond our small size as a niche specialty of otolaryngology. And I believe we have done this very effectively with our guidelines program. So in conclusion, I've tried to open your eyes to what measures are about, where the academy stands at this point, and why you should be interested. I think there will be plenty of information to come. I encourage you to visit the Academy website, which is entnet.org/content/otoregistry, where we will continually updating you on new benchmarks and happenings, as well as at the Academy annual meeting. There will be a lot of new information. So I appreciate your time in watching this presentation and look forward to working you in the future with a Measures Development Group.